So today we're going to talk about psychosis, primary care, and diagnostic overshadowing. It's a topic that I've brought up in the first episode, Psychosis Echo, because we talk about integrated care at least once a year over in that program. So why do we talk about this? If I can get my slides to move, that would be fantastic. There we go. Many individuals who live with psychosis experience physical health conditions that can be treated with the right amount of support, resources, and information. And so it's important for us to keep that in mind because their physical health is a major concern and often gets overlooked. So in a longitudinal study conducted in Israel, the authors noted that while suicide and accidents are high amongst patients with psychosis, the majority of deaths are due to preventable medical conditions. Consistent with historic literature, there was a higher percentage of people with psychosis having a comorbid medical condition, 20% of which showed at least one metabolic dysregulation. And in terms of metabolic load, as the metabolic load increased, so did the risk of mortality. So in that same study, they saw that persons with psychosis utilized both primary care and the emergency department more than the general population. Interestingly, as metabolic load increased, so did the number of primary care visits. This population accessed specialty care far less, but when they did access specialty care, the mortality risk was decreased. And persons with psychosis actually showed better adherence to antihypertensive medications, which I thought was kind of interesting. In another longitudinal study from Australia, they found similar themes. When surveyed about main concerns, finances, unemployment or employment issues, and social isolation remained high over time, but poor physical health actually jumped from 20% reporting a major concern of poor physical health to 43%, despite the fact that they showed an increased number of primary care visits and an increase in physical activity throughout the longitudinal study, and the majority of the patients showing a good, adequate mental health literacy. Their concerns around physical health conditions were still very significant. So just like early detection and intervention are important for the long-term mental and emotional well-being of patients with psychosis, early detection, intervention, and prevention efforts are critical to their physical health needs as well. Metabolic syndrome, hypertension, diabetes, all have been shown to correlate with worse cognitive symptoms. And early interventions such as smoking cessation, weight management, preventive health screenings may reduce cardiovascular and cognitive decline. Exercise has also been shown to improve cognitive functioning. So we know that a litany of things contribute towards worse health in this population. I'd like to spend the rest of this short presentation focused on one of the things that we actually have the power to influence with our individuals that we work with. And that's our ability to identify physical and medical risk and concerns in those patients. So diagnostic overshadowing. So in a 2019 study, the authors wanted to compare the perception of physical health among FEP participants between, so their self-perception of health versus their clinician's perception of health. Those FEP participants, so FEP being the first episode psychosis participants, reported poorer health over time. And interestingly, clinicians had a biased view of when they reported better or worse health. So clinicians, they rated the patients as having worse health specifically when the symptoms of psychosis were still present. So if they were still showing positive or negative symptoms, they were rating them as having poor health. And those who were in remission of psychotic symptoms, they were rating as having better physical health. So why might we rate physical health of FEP participants differently than they rate their own health? One of the possible reasons is diagnostic overshadowing. So diagnostic overshadowing is a phrase that's most commonly used when physical symptoms are misattributed to mental illness. It was formally recognized as a contributor to health disparities following a Disability Rights Commission inquiry in 2006. And as you might expect, it transcends diagnosis and actually influences treatment as well, meaning our biases around mental illness, race, gender, and ethnicity all may have an influence on not just our interpretation of symptoms, but our willingness to address barriers to care, our willingness to recommend certain treatments. All of this is compounded if you have, say, a Black female diagnosed with schizophrenia presenting with physical health symptoms. From a client perspective, a 2021 meta-analysis showed themes that included that physical health symptoms might exacerbate their mental illness or vice versa, making it hard for them to articulate the problem. They note surviving in an ill-suited system was a common struggle. The system feels non-responsive. They feel like it fails to listen and or believe them. It fails to dig deeper and follow up. Stigma leads to many of them trying to hide the diagnosis of a mental illness from physical health physicians. Clients feel capable of managing their physical health needs, but also feel like the providers that they work with often see them as incapable, and all of which is very disempowering to them. So clinicians also reported that the system, especially acute care, is ill-suited to meet the needs of those with severe mental illness. They cite missing the full diagnostic picture due to challenges in communication, challenging behaviors, getting an incomplete history, differentiating physical symptoms versus symptoms of a mental illness. Providers acknowledge stigma once learning of a mental health diagnosis. So they might have negative perceptions of the patient's ability to care for themselves, to follow treatment recommendations, and possibly to recover. Some may even blame the patient and often get frustrated with the patient. So some fear exacerbating the mental illness, and they might even fear violence, all of which leads to avoidance. Since they don't feel like they don't have the training or support from colleagues or the training to do this very well. And clinicians cite workplace system factors such as time, productivity, lack of integrated health services, all as major contributors to diagnostic overshadowing. So the system/environmental issues, so maybe a crowded or noisy emergency department, time and productivity challenges and stresses, a lack of integrated services, and that integration of mental health services into the acute care or primary care settings. Added on to that is communication challenges, some stigmatizing attitudes, implicit biases, all of which lead to, and kind of the result of all of that is poor quality care. So there's a hyper focus on what's known, so the mental illness, and then avoidance, leading to no complete picture, possibly a hasty exam or an incomplete exam, a misdiagnosis, missed diagnosis, and then failure to comprehensively manage, and if it's acute care, hastily discharging patients. So to overcome diagnostic and treatment overshadowing, integrated care is actually advocated for by both clinicians and clients. On both sides of the spectrum, they say that is something that will help, having a more integrated system. We can also improve the training and education of our clinicians, and it's important for us to reflect on all of our implicit biases, and those might be around mental illness, race, gender, socioeconomic status. We all understand the importance of physical health and engagement in preventive health screening, and coordination is really a key factor to all of this, including among your team members, and that team being kind of a broad gamut, because you might not have internal team members, but knowing who you need to coordinate with either on the physical health side or the mental health side. And even things like if a client is sharing that they have a desire to improve their diet, do you have somebody that can, well, either can you work with them on picking options, planning meals, or do you have somebody that can help them do that? So I guess I'll leave it here with what else can we do to better address all aspects of the client's health and well-being, and to catch ourselves with diagnostic overshadowing so that we don't impact our patients negatively.